Hi, my name is Suzanne Mitchell, and I'm the Director of Clinical Services for Archer Health. And I'd like to talk a little bit about palliative care. Palliative care really recognizes the journey of disease, acute to chronic to end of life. When we look at today's healthcare and the continuum that's put together, we might look at it something like this as far as acute care, critical care, rehab care, skilled home care, palliative care, or hospice care behind my picture here. And then there's another area that's called long term care, which is not reimbursed at all in our system, but it's a large part of our system in which we have many family caregivers or we have families paying for that level of care, which is mainly personal care. At a course of an illness, we're really looking at this kind of a picture. So we're looking at we we have symptoms and we go and we get diagnosed and then we're diagnosed with some kind of disease or some kind of illness and we're treated for that. And that's what acute curative care is when we get all of our medicines and our surgeries and everything like that. In the same time that this is going on, we begin to acknowledge an area that's called palliative care. That has to do with symptoms, not particularly the disease. You could have a headache from stress, or you could have a headache from a brain tumor. So that when you're treating the headache, just the headache, you're treating with palliative in mind because you're just treating that symptom of a headache, not curing the disease. So it can start way over here, but as the disease progresses and there's less and less available to cure or get rid of the disease, we begin to look more and more about the signs and the symptoms of what's going on with the disease. That sign could be a caregiver that suddenly keels over and the kids don't realize that the reason that she dies is because she's been caring for an Alzheimer husband for the last 2 years and the kids live out of state. That would be an example, I think, of palliative care not working and not her getting any help. Okay. Uh, and until we get to the point where we're just looking at nothing more that we can really do about this disease thing that's going on. We've already had all of our back surgeries and all of our, we've already had all those things and we're still in pain. Okay. So that's when this level of care called hospice comes in, when we are saying as a professional group, we're only treating the symptom, even if it ends in me dying a little sooner. Okay. So that's the philosophy really over here of palliative care. I mean, of hospice care, if that makes sense. So, just a little bit, like I was saying earlier, as far as acute care or curative, the trajectory is first the diagnosis of the disease and any related symptoms and what we're going to do about them, how we're going to go about curing the disease or treating the disease and alleviating symptoms from the disease. But we're pretty focused on the disease and the problem specifically that the person is having. With chronic disease, of course, we get into the areas of having symptoms from COPD and also having symptoms from heart failure, for instance, and it's all the same patient. When we're looking at palliative care, and sometimes it's a little bit difficult with the area of palliative care that we work in when we're dealing with a combination of acute care and not total palliative care. But the main focus in the trajectory of palliative care is really look at what the patient, what their goals are, if they know what their goals are, and the family, as far as what really are we looking at, as far as what do we want to get from this arthritis problem that we're having, and how these symptoms and other issues are helping or hindering the patient and family getting to those goals. I think you can kind of begin to get the picture a little bit. So then we want to have the interventions assist in moving in that direction. And it might be different. It might be different. And one of the main reasons that we are not comfortable in moving towards palliative care is a word called the prognosis. And I think more of our patients really need to understand that terminology in addition to just diagnosis, because the prognosis is basically what helps a physician to stay in the acute care, as far as what are the things that I can do that's going to help this person stay alive the longest. And that's what their focus is on as far as the benefits of acute care. Just like the doctor saying, if you don't do this, you might not live as long. Whereas when you're looking at chronic illness or advanced illness or serious illness, what we're looking at is that the prognosis may give us a little hint that we want to re-examine our goals. If the prognosis is hemodialysis and the person has been on hemodialysis for a while, their blood pressure always drops when they're on it, they are not doing well with it. What is going on with this dialysis treatment? Is it really a benefit at this point for the patient or not? So then we might want to look at switching some of our goals into more what the patient is saying, I don't want to do this anymore, for instance. And then what treatments and how we can treat, how we can help that person be more comfortable. Some of the difficulties as far as moving folks into understanding palliative care is just exactly what we were talking about as far as prognosis. Who knows how quickly somebody's going to die from what to this, to this, to this. But that prognosis is really the area that we want to look at. Um, the other is a lot of times we don't want to admit that there isn't anything else that we can do for this disease. And sometimes there's not. Sometimes there just isn't another pill. The other thing is that we inappropriately do aggressive curative care and treatment, sometimes when it really ethically might not be appropriate. And the big one probably here is the tendency to put palliative care with end of life and hospice care, and not really seeing that it should be available for any patient. Any patient should not have to suffer from signs or symptoms of their disease. We should try to work on that while we're working on the disease. The other thing is that as far as people that are trained in understanding palliative, and of course the reimbursement, which is not there yet. It's there a little bit with Medicare B, some of the HMOs, but it's moving in that direction, and we're right on the cusp of it, but it's not really reimbursed so much in our regular system for people. Um, and the concern that if we introduce palliative care, it might interfere with whatever is going on that's trying to uh, extend life. like if somebody's on dialysis, okay, and do we want to introduce palliative care? Oh my gosh, they might want to go off dialysis, and that would be a big problem. That sort of thing. Just real quick, this is just kind of a little history, I guess you would say, of palliative care services. Actually, they got started in the hospitals about 20 years ago, really, when hospitals were realizing and hospices were telling them, that too many people were dying in ICU units that really shouldn't be in ICU units, and the ICU units were getting full. And so a lot of hospitals started palliative care units within the hospital. In other words, where somebody still maybe needed to be on a vent, but they were really trying to wean them off and see if they were going to die if they weaned them off, or be okay, that sort of thing. And they were palliative units, and a lot of hospitals have palliative care units. Hospices work with hospitals all the time as far as a term called inpatient hospice. And when you need acute care, and so the two are collaborating more in that way. There's also a new level of palliative care that the community began to see, and Joint Commission and some of the accrediting folks, as far as combining and putting together palliative care, even though not reimbursed, or reimbursed through Medicare B, or like we're doing, we're reimbursing it because we have a skilled need. And so we are using the skilled need to introduce using what we should be using anyway for every patient. If we're looking at patient centered care, uh, we should be using palliative care in some fashion for every patient. These are just some of the common diagnoses that you would see our healthcare professionals looking at more readily, as far as chronic problems that aren't really going to go away, but will linger and get worse and worse and not be necessarily cured. These are some of the common criteria that we would look at as far as making sure that we began to introduce controlling signs and symptoms more than just the treatments and the uh, results of the medication or whatever we were doing to treat the cancer, but looking more at the symptoms of the cancer, for instance. Um, and just as far as the slide right before, as far as community based palliative care, um, that is a certification under Joint Commission for home health agencies, hospices, whatever. Ours, we do not have to be certified in community based palliative care. We are just using palliative care philosophy for all of our patients. Uh, anyway, I know all of you are really well uh, experienced nurses and therapists, and have been doing home health for a while. This is change. This is the new normal. Ever since COVID, everything in the world has really changed, and it's not really going back to the way it was. And so we need to come together as a team and try to change. And that's not easy. That's not easy. But we're going to give it a good go. Okay? All right. Our patients surely need it. Thanks so much for listening. I hope it wasn't too long. Okay? I have another PowerPoint on physical symptoms that I think you'll really appreciate, and it's going to fit in with the goals and interventions of acute care, even though it really is palliative care. Okay.